Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled The Changing Landscape of Oral Health, an introduction to workforce strategies designed to expand access to care. And today's presenters are Margaret Langelier and Jean Moore, both from the Oral Health Workforce Research Center. Now, following today's presentation, you may ask questions using the chat panel on your screen. And after today's event, you will be directed to a short evaluation survey. So please take a few moments to provide us with your feedback. We would greatly appreciate it. And with that said, I'm going to turn the event over to our moderator, Jean Moore, the Director of the Oral Health Workforce Research Center. Jean?
Thanks, David. So one of the things I want to make sure that we acknowledge is that this is a collaboration with the Oral Health 2020 Network. And I've asked Fatima Morales to say a few words of introduction before we begin the presentation. Fatima?
Thanks, Jean, and thanks, David. Hi, everyone. This is Fatima with the Network Support Team. I'm the Network Relationships Manager with the Oral Health 2020 Network, and I just want to thank you all for joining today's webinar. You all have asked for this information, and your Policy Network Response Team has been working hard to meet the needs, the information needs that you all have asked for. So this is just step one in sort of us trying to make sure you get the information and resources you need with regard to workforce issues and just this issue area. And as David mentioned, there will be a webinar or a survey after the webinar. Please complete that survey. It was developed by the Policy Network Response sub-teams, and so we want to make sure that after this webinar, we continue this conversation and tailor additional webinars in the future to meet your needs. So that survey will be the first way that we get a sense of what's the most pressing things that you'll want to learn about, and how should we tailor these spaces to really meet the needs that you have. So just thank you for joining us today. This is first step in this whole relationship. So just hang in there with us, and we look forward to working with you all. So thank you, Jean, for giving us, for partnering with us on this and for starting this journey with us.
Thank you. So before we start the formal presentation, I would like to give you just a little bit of background about the Center for Health Workforce Studies and about the Oral Health Workforce Research Center that the center sponsors. So the center's been around for about 20 years, and we're based at the University at Albany School of Public Health. And we do what our name implies. We study the health workforce with a goal of helping inform public policies. We think that evidence-based research is really critical to informing health workforce planning. And we have a broad array of funders who support our work. So the center has a cooperative agreement with the U.S. Department of Health and Human Services, or I'm sorry, the U.S. Health Resources and Services Administration, HRSA, to run an Oral Health Workforce Research Center. And this is the fourth year of an 8-year agreement that allows us to conduct this research. And at this point, I'm going to turn it over to Margaret Langelier, who is going to talk with you about some of the things that we're seeing and some of the workforce issues around oral health that we think would be very relevant to you and the things that you do. So, Margie?
So, good afternoon. As you can imagine, in 4 years, we've done a substantial amount of work in oral health workforce. Much of the work that we do is qualitative, but we also do a fair amount of quantitative work. And today, I decided that it was probably most helpful to focus on the quantitative pieces, simply because it will give you a better idea of what we've observed happening in the oral health system over recent years. So today, I'd like to talk with you a little bit about key themes that we've observed during our years working in oral health. I should comment here that we have only had the cooperative agreement for 4 years, but our work in oral health extends back almost 15 years. That history helped us to obtain the cooperative agreement with HRSA. The other thing that I'd like to address is an overview of our observations of changes in the oral health service delivery system. We're observing that changes, organic change as a result of systemic influences. We see more evolutionary change than revolutionary change, although there's certainly revolution occurring in some places. Systemic change is generating new workforce models. I'll talk a little bit about some of the workforce models that are happening both within traditional oral health professions and also in medical professions and other health-related occupations. And I'm going to give you a few examples of program and workforce innovation at state and local level. So what are some of the key themes or the evidence of ongoing systemic change in oral health? We're seeing a strong emphasis, I'm sorry, I'm going to go back because we skipped a couple of slides here, I think. Nope, all right. We're seeing an ongoing emphasis on improving oral health literacy. That is a major emphasis in many of the initiatives that are occurring throughout the U.S. We're seeing a focus now on prevention and early intervention rather than on treatment. A greater emphasis on risk assessment, and this is especially important because it allows professionals to appropriately manage patient care and also provide services efficiently. We have a limited capacity of oral health professionals. If we risk assess and manage patients based on their risk, we can use resources in the most appropriate manner. Team-based models of care delivery, you'll hear that a lot today. Integration of oral health services with primary care and behavioral health. There's a drive now to encourage the use of diagnostic codes in dentistry, something that hasn't happened historically. And one of the reasons for this is to enable monitoring of quality and to describe outcomes to evaluate value-based care. We're seeing a growth in use of electronic dental records and in integration of those dental records with the electronic health record. This is very important for integration of oral health services and for establishing comprehensive health homes. Consolidation into large group dental practices. This is happening throughout dentistry currently. It happened in medicine a little earlier, but it's also happening very frequently now for dental practices across the U.S. A very large growth in the dental safety net and in its configurations. We'll discuss that a little bit today. Lots of interest in moving oral health services to community and public health settings, and the use of new technologies and new medications to improve access to services. So the key themes emerging from our research and what we found makes a positive impact on oral health access and the oral health of the population include some of the following. Integration of oral health with primary and behavioral health service delivery. This is a really important initiative that is having impacts on patient access. Workforce innovations. We have expanded functions for existing workforce. We have new categories of oral health workers, and we are increasingly engaging the primary care workforce in oral health service delivery. We have also increased the points of entry to the oral health system. This is especially important because it creates sort of a funnel effect to dentists. Team-based approaches, again, you're going to hear that repeatedly. It's an important theme. Local solutions in program design. I cannot emphasize enough how important local solutions and local program design are to mediating specific oral health access issues. And the improving the insurance status of the population. The Affordable Care Act certainly had an impact on the dental insurance status of patients, probably not as many as we would have liked, but it has had an impact. And we're seeing an uptick in utilization of oral health services among the publicly insured, which is a challenge simply because we do not have enough workforce that treat the publicly insured. So healthcare workforce is the active element in affecting change in oral health service delivery. And yet it's our observation that workforce is often a secondary thought or an afterthought when programs are being designed and funded. There are many components of effective workforce policy in a state, things like the educational pipeline, curriculum, and formal education and training programs, the content of continuing education, competency-based training models. For instance, in Alabama, the state allows chairside training for dental hygienists. This is something that's not allowed in any other state. In Alaska and tribal communities, the dental health aid therapist is a partly formal education model and partly competency-based model. So there are changes in the educational pipeline that are affecting workforce. We have to assure that programs that are training our workforce are accredited to assure quality assurance, and certification and licensure of professionals continues to be important to assure that we have a competent professional workforce. Scope of practice is an extremely important component of program innovation. It's something our center has done a substantial amount of work in. I refer you to our website to see some of the work that we've done related to dental hygiene and dental assisting scope of practice. So there are also structural changes which are more passive supports that are necessary to enable these workforce activities. They include things like supportive regulation, appropriate reimbursement methodologies. If you can't get paid for it, you won't be able to do it. Innovation in technology is really having an impact on where and how we can provide services. The opportunity to practice in expanded settings is such an important piece of bringing oral health services to the population that is in most need. Changes in curricula, again, to accommodate expanded competencies, new technology, and emerging science. As with every other health profession, the science changes constantly. The technology available is always new and emerging, so educational programs need to be very conscious of their need to change their curriculums in order to accommodate these new opportunities. So what are some of the drivers of change in workforce policy in recent years? We talk often about workforce shortages. It's very difficult to say whether or not there are in fact shortages or whether there really are enough but they are not well distributed. However, I should tell you that the number of dental health profession shortage areas changed from 800 in 1993 to 4,900 in 2014, suggesting that we do in fact at least have a distribution problem in many geographic areas and for certain populations. Changing public policy, again, I'll talk about more publicly insured people are now creating demand, and we need to create a system that allows them to find places to get services. The demographics of the population, we have a growing population, growing in diversity, it's an aging population, and yet we still have racial and ethnic oral health disparities that need to be addressed. Limited resources to pay for care, especially in our public systems. So there's a desire within those systems to better target the resources that we have available for care. There's new technology that is certainly affecting our ability to provide services, things like teledentistry modalities, lasers, portable imaging equipment. We have new dental materials, including glass ionomer sealants and silver diamine fluorides, that can be applied by professionals other than dentists, and they forestall the caries, developing caries. We also have interesting consumer demand for alternative providers in healthcare. Patients are very happy with the care of nurse practitioners and physician assistants. They find that they make care more convenient and accessible, and there's a demand for that kind of accessibility within oral health. And we're also seeing a desire for convenient care, and that's driving the consolidations into practices, into large dental practices, dental support organizations that provide weekend and evening hours for patients to access care. So this is a picture of a dental home that's gradually being dismounted. You know, oral health service delivery used to be concentrated in the private dental practice. Providers are now much more distributed and diverse in location and constitution. Many more services are available in community settings. However, providing services in these other settings is a little bit more challenging in dentistry than medicine, simply because of the procedure-oriented nature of practice. Care delivery is now more patient-centered. There's increased efforts to bring services to the patient rather than bringing the patient to the provider. And all of this innovation depends on an oral health workforce working at high levels of professional competence, meaning that oral health workers must be able to work to the top of their licenses, to their education and competencies, in order to use the resources available to them most efficiently. So let me tell you a little bit about the three shifts that we've seen in workforce. So the first is expansion of roles for existing workforce. We have expanded function dental assistants who can now do coronal polishing, restorative and orthodontic services. We have public health dental hygienists, independent practice dental hygienists, collaborative practice dental hygienists in states. They can provide preventive and prophylactic services prior to a patient seeing a dentist. And this may sound like a small thing, but the barriers to seeing a dentist are so substantial that allowing a dental hygienist to provide a preventive service prior to seeing a dentist is extremely helpful because they can screen and risk assess so that, and refer as needed. So this initiative in states has been probably one of the key workforce initiatives that's occurred over the last decade. In many states, dental assistants and dental hygienists can team in community settings if dental hygienists are allowed to supervise dental assistants. So this auxiliary workforce, if you will, can be very powerful in public health. We also have new workforce models, the Community Dental Health Coordinator, which is a model built on the community health worker model. They are trained to case find, care coordinate, provide community and patient education, and also do motivational interviewing. This is an interesting credential. It can be a standalone credential, or it can be an add-on for a dental assistant or a dental hygienist and be very useful in their work in the community. We also now have dental therapists, dental hygiene therapists in many states. These therapists are allowed to provide some basic restorative services, especially for children, and usually the state requires that they provide a majority of their services to the underserved. These models have varied. They're now only enabled in Minnesota, Maine, and Vermont, but there are several other states considering these models. There is a model in Alaska called the Dental Health Aid Therapist, but that is a model that was developed through the federal government, so it's not actually in effect in other state practices. And the other thing that we're seeing is the engagement of medical professionals with oral health screening and referral. Interprofessional education is a major objective now. The federal government is extremely interested in this. They've developed a curriculum. The National Interprofessional Oral Health Initiative has been very active on this front. There is now an online curriculum called Smiles for Life that is accessible to anyone. It trains in how to screen, how to do an oral health examination on children, and it provides some very basic information. It's used by many of the formal education programs. Physician assistant education programs, for instance, often require at least some of the modules for their students. We're also training primary care clinicians, especially pediatricians, to screen and refer children. Medical assistants and nurses in these practices are being trained in the application of fluoride. And we're looking at integration of health services, especially in safety net settings, FQHCs, which we'll talk a little bit about later in this presentation, sort of the pioneers in this effort. So throughout this presentation, I'll be talking to you about differences in local strategies to address oral health disparities. We also need to recognize that there's no set oral health care team. These teams are constituted differently in different settings. So for instance, if you go to a dental clinic in a federally qualified health center, you may be in contact with a dentist, you may have dental students doing externships, dental residents completing a year of residency while they're there, you may have specialty dentists, you may have general dentists, you'll have dental hygienists and dental assistants, some of whom are working in expanded functions like orthodontics. In these settings, you're also going to interface with community health workers that are working as patient navigators. You're going to interface with medical clinicians and with social workers. In a nursing home, where services are now being provided, the dentist and medical director are part of the oral health team. They will have constant consultations on medications, for instance, that are affecting the, are creating dry mouth in the residents of the facility, for instance. You will also, the certified nursing assistants in skilled nursing facilities is a really important piece of the oral health care team, simply because they assist with helping patients for daily hygiene. So in primary care medical practices, you have primary care physicians, family practice doctors, you have nurse practitioners, medical assistants, and in some cases now you even have dental hygienists who visit the practice to provide services. These teams also vary depending on the modality of care. We've done some work in mobile dentistry and in teledentistry, and it's very important to have community liaisons that are working in the facilities that you visit. So people like school secretaries, for instance, or a social worker at the nursing home are all part of the oral health care team, helping to manage the care of patients while the oral health providers are within the facility. Even information technology personnel in the teledentistry initiatives that we've seen are extremely important as part of the oral health care team, because they help to manage you know, all of the technical piece of providing those services. So again, oral health care teams expand or contract depending on the particular focus or the need in the patient population. Again, there is no standard template for program design. We found that programs are designed based on the need in the population, based on an evaluation of existing oral health resources and providers in the community. So many safety net providers have said, we need to be sure that we aren't duplicating services that are already available to our patient population, simply because we have limited resources and we need to use them wisely. State regulation regarding requirements for dental supervision of allied dental workforce. This is extremely important when in a few states, their dental hygienists are only allowed to work under direct or indirect supervision of a dentist. This really means that unless a dentist is present in whatever facility the dental hygienist is working, they cannot provide services. So dental supervision is key. That's expanded. There's lots of expanded opportunities in most states now that do not require direct dental supervision, but there's still a few states that do require that. Scope of practice laws are very, very important in that they enable the practice of dental hygiene. Can a dental hygienist, for instance, clean teeth before a dentist has seen the patient? Insurance regulation is another piece. I was just looking at some regulation in Maine today. They, in 2015, they had to change their insurance law when they enabled dental hygiene therapy, and they also included independent practice dental hygienists, mandating that insurance providers in the state pay them for the services that they provide. So I thought I'd provide you just with a couple of examples of state strategies to provide opportunities for expanding access. States differ, as do localities. So I'm going to give you a few state pictures and then talk to you a little bit more about local initiatives. So Maine is probably the exemplar state in that it's enabled every kind of oral health workforce that is probably known to man. Maine has enabled all kinds of dental hygiene practice, including traditional dental hygiene practice, public health dental hygiene practice, independent practice dental hygiene, and dental hygiene therapy. So there's a range of opportunities based on education, experience, and competency for dental hygienists in the state. There is expanded function dental assisting is also allowed, and there's a number of certifications within the state based on whether it's orthodontic, restorative, preventative. They have an initiative into the mouths of babes that trains primary care providers to screen and place fluoride in the mouths of young children. And they also license denturists, one of only 5 or 6 states in the U.S. that licenses denturists to provide direct access for patients to prosthetic devices. Oregon's another example of a state that has done some innovation. They're using pilot authority to test innovation before they actually institute innovation. So right now the state is funding a pilot program in teledentistry that uses expanded function dental hygienists who are authorized to place atraumatic restorations with appropriate training. And the Oregon Health Authority has recently authorized the Northwest Portland Area Indian Health Board that serves 9 Native American tribes to conduct a dental pilot project using dental health aid therapists like they use in Alaska to deliver oral health services to patients. These programs have to report to the Oral Health Authority, and then they'll determine whether or not these things can be offered to others in the state. Michigan is an interesting state because it sort of has an abundance of local initiatives, but it also has had some very effective statewide initiatives. So there is a program in Michigan called PA 161 that allows for collaborative practice between dental hygienists and dentists to work in nonprofit agencies providing dental hygiene services in a variety of settings. In 2016, there were more than 300,000 oral health services provided through this program by approximately 200 dental hygienists supervised by approximately 100 dentists. There are 58 programs. 46,000 children had an oral health screening, mainly in schools, on account of that program. Michigan is also contracted with Delta Dental to manage dental services for Medicaid-eligible children and CHIP-eligible children in the state through the Dental Healthy Kids Screening Program, and this program has received a lot of national attention because it was not only able to increase utilization by Medicaid-insured children of oral health services, but it was able to sustain that increase over a period of time. There are also some very interesting local initiatives in Michigan. Points of Light is a web-based service to connect children with dentists. It was started by a pediatric dentist to link pediatricians to community dentists willing to treat Medicaid-insured patients, and that initiative is actually extended to several other states. Calhoun County, I encourage you all to look at this particular initiative that happened around Battle Creek and the old Kellogg factories. It's a pay-it-forward health initiative that engages community service providers, dentists, and patients who must earn points to
Someone asked what was the name of the Michigan program. I believe it was the first one that you mentioned.
Oh, it's PA 161. Sorry, PA 161. And if you look it up on the, if you just do a web search on PA 161, you'll see the program.
Thank you. Sorry to interrupt.
So anyway, in Calhoun County, low-income people who have no dental insurance are required to volunteer, and their volunteer hours equate to a certain value for dental services. This program has really been very useful. Dentists participate. They're allowed to have a certain basic stipend, but many of them don't even take it. And the volunteers can accrue hours through their volunteer work for dental services. You know, I asked someone who was telling me about this program whether or not everyone could really volunteer, and she said, we have yet to have a patient that can't volunteer. She spoke of an older woman who was confined to a wheelchair because of severe diabetes, and she said her volunteer work consists of knitting caps for babies in the intensive care unit at the local hospital. My Community Dental Centers, again, is another very interesting initiative in Michigan. It's a consortium of 19 county and regional departments of health. It's created the largest group dental practice in the state, and it focuses on care to underserved populations. It's a consortium that operates in addition to the federally qualified health centers in Michigan. So innovation is driven by local need, creative uses of resources, and engagement with available workforce. And this varies. I can't emphasize enough how the opportunities within states vary because of a number of factors that I've already previously mentioned. And what we found among innovators is that they review the landscape, they understand what they want to do, and then they look for ways to do it. And what they do is they use what is available to them in the states, in the regulatory process, the reimbursement system, whatever, to create some of these programs. And I think it'll be interesting for you to see some of what local people have done as far as innovation is concerned. A few examples might be that, you know, in communities where there's a lack of fluoridation in the community water supply, it's important that children in schools get fluoride supplements. That's not necessarily important in every community. One of the mobile dental programs that we visited recently was the FQHC that sponsored was located in a very large county, but they didn't provide mobile dental services within that county because there was another mobile dental service provider already in existence in that county. Instead, they decided to focus on 3 surrounding counties that were a distance from their FQHC. Another FQHC that we visited recognized that there was a need for asthma management services, immunization services, as well as dental services among school children in an area. And so they decided that they only had limited resources so that they could equip a mobile van to be used for dual purposes, interchangeably for health and or dental services. So some days the van is out doing asthma management and other days it's scheduled for dental services. Another FQHC that we visited decided that they should have an open door policy for migrant workers simply because they recognized that farm workers could not always get a ride into town for a scheduled appointment, and also that during rainy days or snowy days, they might have time off that would allow them to come in. So migrant farm workers were allowed to show up at any time for a dental or health service. The FQHC would guarantee that they would be seen, not necessarily that every one of their problems would be addressed, but that they would be seen and any acute problems could be handled. So these are examples of local innovation, many of which involve using multiple resources. The first is a mobile dental program in North Carolina. This program began as an initiative of the North Carolina Dental Society. It's grown substantially and really is the sort of material evidence of the vision of a particular dentist who now manages this program on his own. He certainly has other dental partners, but it's mainly his vision. The program delivers services in 86 facilities in 23 counties in North Carolina. The patient populations are only those with compromised access to oral health services. Just as an example, dentists and dental hygienists provide services in the Regional Center for Infectious Diseases for HIV-positive patients 3 to 5 days every month. This is really a beautiful example of integration. The dental hygienists and dentists interface with the medical professionals in that setting on an ongoing basis regarding things like pre-medications that are needed for some of these patients, interactions with medications, et cetera. The demand is so great that they've recently had to increase the number of times that they visit this particular facility. This program also visits programs for the developmentally disabled, PACE programs, nursing homes. It's quite incredible. They provide a full range of dental services, including same-day dentures, and the dentist provides surgical services in hospitals near patients' homes. So he has hospital privileges in several of the different counties where hospitals are located. This is a mobile dental program that's really part of a comprehensive system of oral health service delivery. The SMILE program at Eastman Institute for Oral Health has 5 mobile dental vans. It's one of the oldest mobile dental programs in the country. And they routinely locate at neighborhood schools for children from low-income families in Rochester, New York. Rochester, the main zip code in Rochester is one of the poorest in the state and in the country. One of their units, one of these 5 units, is actually equipped with a wheelchair lift and an air glide chair for special needs populations. They serve the needs of approximately 2,000 children in 17 schools each year. And during the summer when schools are closed, they travel to surrounding counties which are more rural than Rochester to serve adults and children in need of services. For many students, the mobile van is their dental home. They're scheduled every year for routine services, prevention services, maybe minor restorative services on the vans. But for those who need more extensive services, Eastman also has some school-based health centers, and they have a very large and comprehensive specialty clinic that can receive referrals from these vans for the children. So there's a very good system of care for kids from low-income families. So this program was actually founded by a dental hygienist in Colorado, and I in Colorado, dental hygienists are allowed to practice independently. She became very concerned about the oral health status of people living in skilled nursing facilities, so she began to provide and struggled to provide services in skilled nursing facilities. And over time, with change in regulation in Colorado, she was able to expand her practice to now include a full-service fixed clinic that has dentists employed by the organization. She also operates a mobile program, and she operates a teledentistry program. So the dentists and dental hygienists work in the fixed clinic, seeing low-income seniors who are mobile. They still provide services for residents of nursing homes. They use the mobile services and locate in community centers for seniors in rural areas. They even have a clinic and a municipal housing project in Denver. Her teledentistry efforts, she's equipped this van that you see with a Panorex machine. So when the dental hygienist goes to the nursing home, she can have the elder wheeled to the van, which has a ramp. There's a Panorex machine, which is much more agreeable to elders versus the 4 different x-rays, to acquire images, and those images are stored and forwarded to the dentist in the fixed clinic, who can do treatment plans while the dental hygienist can provide preventive services in the nursing home. This is a story about an FQHC in Pennsylvania. It's Wayne Memorial Community Health Center is part of the local hospital system, but it's the only dental provider in the county that accepts Medicaid. So they use expanded practice workforce in various ways, very interesting ways. So in their fixed clinic, which has very, very high demand, expanded function dental hygienists are providing the local anesthesia before restoration. Dentist comes in and drills the teeth, and then an expanded function dental assistant fills and carves the restoration. In the community, they have an expanded function dental hygienist who also has a community dental health coordinator certificate. So she does lots of community education, case finding and outreach, and she goes out and provides oral health services in the primary care practices that are part of the FQHC in the community. Teledentistry services are becoming and increasingly used as a strategy to address the needs of the underserved, particularly those in rural areas who have long distances to drive to receive oral health services. This FQHC, Finger Lakes Community Health, again, is probably a benchmark for telehealth and teledentistry. I think they provide 7 or 8 different telehealth services in collaboration with partners all over the United States. This particular slide focuses on the teledentistry services that are provided to children from low-income families in rural areas. So these children have, even though Finger Lakes has general dentistry clinics, the general dentists have determined that they cannot treat these children within any of those dental clinics. So this teledentistry allows for synchronous specialty dental consults in real time. The dental specialist is located at the Eastman Institute for Oral Health in Rochester, which is located, somewhere between 20 and 100 miles from one of these FQHC clinics. A Finger Lakes dentist or a dental hygienist is with the patient at the dental clinic during the consultation. The pediatric dentist is at Eastman. They have a 97.2% treatment completion rate. Some children require only a single visit. Others have required as many as 5 to the specialty clinic in Rochester. But the outcome is that 77% of the children that are seen through one of these consults subsequently established a dental home at one of those clinics. This is a virtual dental home. It's happening in Salem, Oregon. I'm going to kind of speed through this because I realize the time is advancing. I want to tell you a little bit about some dental hygiene practices. Dental hygienists are working in school-based programs in very interesting ways. These are dental hygienist entrepreneurs who own school-linked and school-based oral health programs. providing a range of oral health services for school children. In South Carolina, the 17 dental hygienists provide preventive services to approximately 23,000 children in 46 school districts. Many are Medicaid eligible, and this program relies mostly on Medicaid reimbursement. In Nevada, a dental hygienist has a program that sees about 4,800 children annually in the 5th largest school district in the nation. Dental hygienists provide preventive services in both fixed and mobile format. She provides all of the sealant information to the state sealant program. She participates with that. These services are mainly supported through grants and philanthropies through some of the foundations from the casinos in Las Vegas. I want to quickly address FQHCs because they are important innovators in the communities that they serve. Their services are co-located. It does not necessarily mean that they are integrated, but in many cases it facilitates integration simply because it reduces the structural barriers to integration and allows for warm handoffs across disciplines. FQHCs can provide a comprehensive health home. They have mission-driven workforce, often integrated electronic health records, and they can use innovative oral health workforce models in team-based care. So some of the strategies that they're using are requiring all primary care patients to receive all oral health patients to also be primary care patients. They're routinely scheduling the dental hygienist during periodic well-child pediatric visits to provide an oral health screening. They are offering services in their school-based health centers, in mobile and portable programs, or using teledentistry. They are building connections with other providers in their local communities. And the remainder of these slides really do give you a few examples of some of the efforts at integration that we've seen in FQHC. So I think I should stop there and allow you to ask any questions that you may have.
So Margie, we have one question. Someone wrote, I'm interested in knowing more about when NCQA may add dental as a measure. As we know, there is a systemic relationship to mouth and body, and some patient-centered medical homes have integrated dental conditions as part of their programs. It seems appropriate to have NCQA add a dental measure. Any thoughts?
I agree. I'm sorry I can't give you any actual information about when that might happen. We've also discussed among ourselves here at the center that even having HEDIS measures related to oral health would be extremely helpful for affecting integration of oral health services into primary medicine. So we think there are some larger structural and federal initiatives that could help sort of achieve some of these the goals of integration and improved accessibility, but unfortunately I have no information on NCQA and what their intentions are. I wish I could be more helpful.
Another question, how many dental therapists are licensed and practicing in Maine and Vermont?
Well, Maine and Vermont are really in the beginning stages. I think they're still working on getting the education programs in place. I think Maine has made some progress in getting a program established. I don't think they've admitted yet, and Vermont is only at the beginning stages. The curriculum, one good thing is that a curriculum has been approved by CODA for dental therapy, so a standard curriculum is available. It's just a question of sort of working out the educational pipeline to get these dental hygienists into training. Both of those models, by the way, are dental hygiene models, meaning that the people who will enter those programs must be dental hygienists.
Another question, are any of the local innovation programs that you described unionized?
You know, again, whether or not a facility uses unionized workforce would very much depend on the local situation. My suspicion is, for instance, here in New York, that many of the innovations that occur in federally qualified health centers must work around union workforce. I'm not necessarily, upstate, that's not necessarily true. My suspicion is that in most cases, the unions are not involved, but I'm certain there are cases where they are.
For some of the local innovation projects that you described, what are some of the major hurdles they face, either in the program planning stages or in implementation?
I think the program, the hurdles that many encounter are reimbursement probably rises to the top, although I hate to make reimbursement, the main part of the picture. But for instance, in teledentistry innovation, there's lots of discussion about who is being reimbursed for those services. Certainly the person doing the consult is expecting reimbursement, but the originating site also needs reimbursement for the cost of the equipment and managing the consult, et cetera, et cetera. So it's true for dental hygienists. In many states, they must have a supervising dentist in order to be paid for their services. In South Carolina, where those 23,000 school children are seen, there is a Medicaid participating dentist who provides the protocols and helps with the billing in order for them to be able to provide services and be paid for them. The other major obstacle is scope of practice. I think that's changed over the last 15 years considerably, but there are still many hurdles for dental hygienists and alternative workforce to be able to provide services in public health or community settings in the most seamless way. For instance, some of the programs may use teledentistry. We saw a program in Georgia, and Georgia's recently changed their legislation. It was a teledentistry program because dental hygienists could only provide services that were determined to be necessary by a dentist. The state was using teledentistry in real time for the dentist to actually be able to look at the teeth of the children with whom the dental hygienist was working, and he could then instruct her to go ahead and provide the preventive services. She was not permitted to make that decision before the dentist had given her that permission. Georgia has recently changed their legislation, though, so I don't think that's going to continue to be. But so only real-time teledentistry was, a possibility in Georgia simply because Store and Forward was not, going to meet the scope of practice requirements.
Margie, here's an interesting question. What is meant by practicing to the highest level of your training? What is an example of someone not being able to do that? Wouldn't this be governed by a Practice Act?
It is governed by a Practice Act, and that's sort of the point when we talk about scope of practice. So let's talk about things like local anesthesia, for instance. Most dental hygiene programs train dental hygienists in how to use local anesthesia. And yet, until recently, many states did not permit, in regulation, dental hygienists to provide that service. That's happened over probably the last 8 years or 10 years. Things like laser technology. This is a question that arises a lot lately. Can dental hygienists use lasers? It's becoming more useful in scaling and root planing procedures, and some states will address it by saying that they can use a new technology as long as the dentist that they're working with has equal or better competency in that technology than the dental hygienist. Other states will specifically exclude lasers, for instance, for whitening, but will allow it for scaling and planing, even though a dental hygienist may be trained in both. So their educational programs are really generally training dental hygienists in some of the newer skills, application of glass ionomer sealants or atraumatic restorations, and yet states either limit or prohibit use of those skills in practice. You can have a dental hygienist who can, for instance, in one state, they may be able to independently do any of those services, atraumatic restorations, preventive services, scaling and root planing, without the supervision of a dentist, direct supervision of a dentist. They can cross the state border and not be allowed to provide any of those services, even though they do have those competencies. We used to say that, a decayed tooth is the same on a patient whether they live in Georgia or whether they live in Mississippi, and that's true of a dental hygienist. They're trained in a national, in an education program that is nationally accredited. They have to pass clinical boards and a national board of dental hygiene, and yet their practice varies depending on the state regulation. And when we say top of licensed practice, we mean to the competencies that they've been trained and proven to be competent to provide.
Margie, it seems that federally qualified health centers have large and diverse teams providing oral health services. Why do you think this is?
Well, it's very interesting because I think that FQHCs really do have the opportunity to be innovators in a way that's very different from many more siloed providers. They also have access to lots of new programs, and it should be recognized that many of the initiatives in workforce and in funding are for the underserved, and because FQHCs treat the underserved, they can take advantage of that. So for instance, in many states where they're passing dental therapy laws, those dental therapists are required to see at least 50% of the patients must be either Medicaid eligible or below a certain income threshold. Who is serving those patients but FQHCs? So in many ways, FQHCs have the opportunity to innovate differently than those who are in private practice. FQHCs have different sort of payment mechanisms. There is a drive in dental education, for instance, to give dental students and residents experiences in public health settings. So dental schools and dental residency programs are looking for rotations in FQHC simply because it exposes the new dentists to different populations than they would see in a private practice. So there's lots of reasons why FQHCs have the opportunity to innovate in a way differently than those in the private sector.
Do you think the private sector could benefit from adopting some of these more innovative models?
Well, certainly. I mean, I'm not even sure the private sector would benefit as much as the patient population might benefit.
True.
It's not always possible for the private sector to adopt all of these innovations. However, there's certainly opportunities for the private sector to participate at a greater rate with care for the underserved.
You talked about the reimbursement challenges that a lot of the innovative programs face. What are the other sources of funding for local innovation programs?
Well, one of the things that I've learned from some of these innovative programs is that they are creative in seeking funding sources. There are many of these groups seek foundation grants. There are local foundations that are very interested. There's philanthropy. FQHCs raise money, outside of their reimbursement streams, et cetera. I think that many of these programs struggle to remain financially sustainable. For instance, the dental hygiene program in New Mexico that is located in and around Las Vegas really does depend for 95% of their funding on the foundations within that area, many of whom they employ casino workers, people in the entertainment industry, and the children that the dental hygienists are seeing are the children of these workers. So these foundations are very interested in helping their workforce. The problem is that the founding dental hygienist spends a lot of her time seeking funding from these foundations on an annual basis, some of whom willingly, give it to her, and others that it takes a bit more effort. So she spends a lot of time tracking outcomes, counting patients, writing grants that make it difficult. But, and I wouldn't say that there's a consistent stream. I've heard so many ways, creative ways of financing, for instance, care for patients in skilled nursing facilities. There's no Medicare benefit. Some of them do qualify for Medicaid, but in many states, Medicaid doesn't pay for an adult dental benefit. There's certain states allow post-income treatment of eligibility that allows them to pay for dental services. So again, there's not one particular reimbursement stream or funding stream that's consistent. It's very locally driven.
Final question. What current research projects is the Oral Health Workforce Research Center working on?
Well, this year we are doing a consumer survey to find out what consumers' experiences are with finding healthcare providers and who is providing them with services. That report should be completed probably by December of this year. We're doing something to look at gender diversification in dentistry. We want to understand if there are any differences in practice between male and female dentists, or whether there are just generational differences in practice. So that study should be completed. We have some data that we're currently analyzing. That study should be completed in August. We're beginning next week some case studies in the integration of oral and behavioral health. We'll be visiting FQHCs that have, you know, large homeless populations, veterans populations, people who are at high risk for mental health or substance abuse disorders, to find out how that's being integrated. And that report, again, should be available this summer. We're doing something on the pipeline. We're looking at dental residency programs that train dentists in public health settings to determine whether or not they make a difference in the eventual practice setting that that dentist chooses. And that should also be available by the end of December.
So that's all the time we have today. When you exit, you'll be directed to an evaluation. So we'd really like your feedback if you found this helpful, if there's more you'd like to know about.
And I would direct you all, if you're interested in the reports that we've already written, to the oralhealthworkforce.org, which you'll see the website at the corner of these slides. Please, many of the reports are available on our web.
Thank you all for joining us today.
Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.